Dr. Anand.
Okay. Hi, everyone. I'm Priyanka. I'm one of the R3s in the primary care track, and I'm going to talk to you today about contraception from a primary care perspective. Okay. I have no disclosures. I will say I'm not doing this talk because I'm an expert or have a lot of experience in contraception, but actually because I recognize it's something I don't do enough in my primary care practice, and so wanted to learn more, and hopefully we can learn more together. So here are the learning objectives for today. After today, I hope you'll feel comfortable discussing contraception and assessing patient preferences in a patient-centered manner. I hope you will deliver inclusive, respectful contraception counseling that is sensitive to issues of racial justice and gender diversity. I hope you will understand the effectiveness, benefits, risks, and side effects of common forms of contraception, and know resources for patients and clinicians to learn more, as well as offer emergency contraception, STI services, and PrEP where appropriate with your counseling. And here's a roadmap of what we're going to cover today. Again, the goal is not to cover advanced concepts today, but really just to kind of refresh our knowledge on contraception and have a little time to just get comfortable with practicing or refreshing ourselves and how to bring this up in a clinic visit. So we're going to talk about putting contraception on the agenda during your clinic visits, about an approach to contraceptive counseling, and some scripts that we can practice about bringing up contraception and assessing patient preferences. And then we're going to talk about some of the attributes of contraception, including efficacy, benefits, side effects, and medical contraindications. And then we're going to talk about some other considerations during your counseling, such as emergency contraception and STI risk. So we're just going to start with the case. These are all cases from my clinic with maybe a little changes, just because I think it's interesting to learn from real cases. So this is a 43-year-old cis woman who's presenting for an established care visit. Her chief complaint today is anxiety and low mood. And she's coming because she was referred from an ED visit where she presented with palpitations and they thought she had an anxiety attack. Her other past medical history includes high blood pressure and GERD, for which she's on losartan, and omeprazole, which she's been on for many years. She's due for a pap smear. She's also due for her COVID vaccine. This was a couple of years ago. And she is monogamously married. She has 3 kids, recently lost her job as a house cleaner due to COVID and is a little stressed out about that. No drugs, does rarely drink alcohol, and she doesn't want any more kids. And those are her vitals. So my first question is just, what's your agenda for this? This is your first visit with her. What's your agenda? And there's no wrong or right answer despite the topic of this talk. So you can have more than one. If you want to put more than one in the chat, that's fine. But what would you address today?
And Priyanka, I could launch a poll, but it just has A through E.
Yeah, totally fine. If people just want to put it in the chat or pick one on the poll.
Wait, actually, I think
made new ones.
Devel made them. Ah, amazing.
Yeah, pick your most important thing. If you can't pick one, you can put it on the side in the chat. Okay. I'm seeing depend on her priorities and some A, B, and E. Okay. And if people are done with the poll too, we can see. Okay. So yeah, her chief complaint was her mood and anxiety. And a lot of people have chosen that. And people are concerned about the high blood pressure that doesn't seem well controlled. And then thank you. I know it's like contraception talk. Some people chose contraception. The goal of this question really is to say that it's hard to put contraception on the agenda always, because it doesn't always feel very urgent. And there are other issues that come up that feel more urgent. And also, we all have our own biases as to when we bring up contraception. And I definitely notice that in women like this that are sort of older, we think or have a less high risk of becoming pregnant, I don't necessarily always put it up there on my agenda. And so it's just a moment of reflection about that. And so who should receive contraception counseling? Really any patient premenopausal patient who can get pregnant and would like to prevent pregnancy should be offered a discussion on contraception counseling. And that can be as simple as just asking, would you like to discuss contraception or pregnancy prevention during the visit today? Acknowledging that it's not always easy to make time for that during your agenda. And then before we kind of talk about an approach to contraception counseling, again, there is no wrong answer to this question. Which, if any, of the following statements do you agree with? Do you agree that sexually active patients who are able to conceive and not planning pregnancy should be on contraception? Do you agree that long-acting forms of contraception like an implant or an IUD are preferable to short-acting ones? Or do you agree that physicians should not influence a patient's contraception choices? Or none of the above? Or if you have thoughts that do not fit into a single letter about these statements and want to put it on the chat, that is great too. There's no wrong answer. This question is really to kind of frame our discussion about contraception counseling going forward. Okay, I see a comment about putting qualifiers. If you want to put your qualifiers in the chat, please do. Again, this is not a right or wrong answer to this poll. I really wanted to hear your thoughts and kind of discuss. I agree with B. I think A and C depend on the patient's knowledge level and comfort with their ideas of what contraception they're interested in. Okay. So it sounds like one person, okay, so a lot of people agree with A, and if fewer people chose B or C, interesting. And someone else said, agree with A and B, depending on the patient's priorities, and C, it may be helpful for some patients to have a recommendation. Okay, great. Other thoughts? Someone mentioned that the long-acting form really dependent on the patient's timeline and future desire for pregnancy. One person is mentioned, which we're going to talk about too, the bedsider tool with patients in the room. Great. So yeah, I'm hearing a lot of different thoughts. Obviously, these statements may be too strong, and so people have mixed thoughts about them. Long-acting forms often preferable, but there's a complicated history, especially with race. Yes, love all that. Okay. So an approach to contraception counseling. I love everyone's comments, and we're going to talk a little bit about, I think all of these statements are statements that I, at least in my training in medical school, have had either explicitly or implicitly have received from someone or have been endorsed. So these are all things that people do believe and teach us. But I actually do agree with people who want to put qualifiers on all of these. And I hope that the approach that I can tell you about contraception counseling, rather than coming in with an idea about what is the right contraception choice or whether someone should be a contraception, really focusing the patient's preferences, which I heard a lot of people say in the chat, is hopefully I can give you that perspective during this talk. I've had patients who intend to become pregnant but would rather have an acceptable unplanned pregnancy than be a contraception. Yes, great. All great thoughts. So here's kind of a general approach to contraception counseling, starting just by establishing rapport, understanding that trust is really important in this discussion, identifying the patient's reproductive goals. And we're going to go over some scripts over how to just kind of start talking to patients about what their reproductive goals are, whether they desire future pregnancy and current pregnancy, understanding the medical history, because this is where you really come in as a physician, understanding potential medical contraindications to different types of contraception. And then kind of the meat, which a lot of people touched on with the last question, and I loved, the shared decision-making. So this is the part where you really want to elicit patients' preferences. And we'll go over some scripts of how to do that as well. Starting with like a question of, do you have a sense of what is important to you about your method of contraception is a great way to start. And then we can go over kind of more detailed ways to kind of elicit those preferences. And I definitely want to suggest here that our contraception counseling should be non-judgmental and non-directive. And studies have shown that patients who felt like their clinician had a method preference, and so a lot of us have at some point, I think, been taught that we should, for example, prioritize LARC methods in our contraception counseling. Usually those patients were less satisfied with their method. And that also means that patients who are less satisfied with their method are less likely to continue that method. And so that is a poorer quality family planning encounter if the patients leave with a lower level of satisfaction, feeling like the physician had a preference for what they chose. And then also what some people mention, and I love that, being open to ambivalence. For many people, pregnancy intention is not binary. For many people, an unintended or unplanned pregnancy is not necessarily a bad outcome. And so people don't necessarily have a perfect reproductive life plan in which they know periods in which they don't want to be pregnant and periods in which they want to pursue pregnancy. And being open to all of that, I think, is an important part of contraception counseling. And before we go into some scripts and just kind of practice saying the words out loud, I just want to talk a little bit about an equity lens for contraception. So we do know that Black and Hispanic women have a higher risk of unintended pregnancy. And for Black women, the rate of unintended pregnancy is somewhere in like the mid 60%, compared to white women where it's more like the mid 40%. We also know that Black and Hispanic women have lower rates of contraception use for a number of reasons that we could get into. And I think that there have been pushes in past years taking these two sort of facts into account to push higher, more effective forms of contraception, generally in the public and then towards women of color. And I just want us to also be aware that patients of color experience poor quality family planning care. And studies show that they're more likely to feel pressure to use contraception by their providers. They're more likely to be recommended LARC. So when physicians are presented with the same patient case, but the patient is white or versus Black, they're more likely to recommend to Black women that they use long-acting forms of contraception. And they're more likely to encounter barriers to LARC removal when they want to discontinue those methods. And so I would like to argue that the focus on just efficacy alone, it ignores patients' autonomy and can often bring up a history of reproductive coercion, including things like forced sterilization and reproductive experimentation. And so it's really important that we now, I think there's been a appropriate kind of swing back towards a patient-centered contraception counseling that really tries to center the patient's preferences. Oh, and I see some chat on the side. Consult to the Women's Health Pharmacy and the VA. Awesome. And some studies have shown that women of color report valuing things like ease of discontinuation, no change in their menstrual periods, STI protection, and control over when to use their method, which isn't to say that any group of people have the same preference and each person has their own preference, but all those things are things that are not actually best suited to a long-acting method of contraception. And so just being aware of both the history that we're bringing up in our medical encounters with patients and the importance of really focusing their preferences, despite, I think, some of the messaging and training that we've got towards a heavily focused towards long-acting methods of contraception. And if anyone has comments or wants to like unmute themselves or put a chat on here, I'm happy to have more discussion about this. Okay, I will move on then. And then another just kind of brief aside before we go into some of the scripts, contraception in transmasculine patients. There was a really great academic half day that I think Lindsay gave last year on like contraception in trans patients in general. And so I'll just mainly refer you to that, but just to say that patients with the uterus and ovaries can get pregnant, and patients who are on testosterone may be amenorrheic, but it's not a reliable form of contraception. And testosterone is also teratogenic in the first trimester when many patients will not be aware that they're pregnant. And so transmasculine patients should also have a conversation with a provider about contraception. And this also is a group of people in which you should be aware that they probably had prior negative healthcare experiences. And so things we can do are ask patients what language they prefer, kind of go into it using less gendered language. And I like this little chart on the side, which has some suggestions for less gendered language we can use when we talk about contraception. And then there may be specific considerations that we can think about when we're offering contraception to transmasculine patients. And I found this chart to be helpful. I'll just leave it as a reference, but which methods, for example, contain estrogen and progesterone, what their effects may be on spotting, bleeding, cramping, chest pain, and whether they require pelvic procedure and how private the methods are all things that we can think about. So I'll pause for questions and comments before we go into sort of just practicing phrases for talking about contraception. Any comments, questions? Thoughts about anything different or specific cis male providers should do when approaching these conversations? I don't know if I have thoughts about ways that cis male providers should approach these conversations differently. I think that, you know, in general, the same things like building rapport, asking patients what language like to use, and being respectful. Yeah, I don't know. Other people have thoughts about ways that you can approach this differently. Okay, all right. So I will go into just some scripts that we can practice. I find these helpful just to be a little systematic about talking about contraception, but also recognize that they're a little bit clunky, and we can have our own ways of having these conversations. And so the most kind of general way to introduce contraception on the agenda is a question like, would you like to discuss contraception or pregnancy prevention today? It's broad and doesn't kind of pin the patient down into particular reproductive life plan or goal, just kind of, is this something you want to discuss today? But there are other questions that have been suggested that I'll let you read. But there's the reproductive life plan set of questions. I find these to be a little rigid because they really expect the patient to have an idea about when they may want more children or children. There's the one key question, which is very focused on current needs. So would you like to become pregnant in the next year? And I think that's nice because recognizing that those needs may evolve over time. And then there's the path questions. And I like those a little more than the reproductive life plan questions because I think they're a little more open to ambivalence on the part of the patient. And then as far as ways to ask about preferences, often people come in knowing what they value in their contraception method, or they've had experience with a particular method in the past, and so they already have opinions about it. And so definitely starting broad with, do you have a sense of what is important to you about your method, or even do you have a sense of what you want, can be helpful. But some people may not be sure, and they may want a little more guidance. And I think that's when asking specifically about different attributes of contraception can be helpful in guiding the patients. And someone mentioned the bedsitter tool, which I also love. Visual aids or decision aids, I think, are super helpful. But if we don't immediately get a sense from the patient about what they value in their contraception preference, I think it can be helpful to specifically ask about method, about frequency, efficacy, about bleeding, what bleeding becoming lighter, going away, becoming heavier, about particular side effects they care about particular benefits they may care about, or about questions about privacy. And so those are, I think, just some scripts that you can think about as far as bringing these up to patients. And then I actually kind of wanted to just take a moment for people to just practice on their own. So just, if you want to turn off your screen, that's fine. I'm going to set a 2-minute timer and I'm going to go back to the screen. And I just want you to say some of these words out loud because I think that it's helpful just to say them and then decide if you like the scripts or not, if it's something you might use in your practice, or if there are other things that you prefer or that you find more natural when you're discussing contraception. So I'm going to set a 2-minute timer. And then I'm going to leave the screen up. And then if you can just literally just say these words out loud, and then we'll regroup and you tell me how that felt. And if that felt comfortable or clunky, or if there are other things that, or ways that you discuss contraception in your visits. So we can start now. Okay, it's been about 2 minutes. I'm gonna move away from the slide. Okay. All right. So I would love if people could unmute or put in the chat. Are there phrases that you liked using? And if you want me to go back, I can go back. Are there ones that you thought were awkward? And are there phrases that you use in your clinic that you would recommend or you could share with us or even say aloud? That would be great.
I feel like, again, a lot of this is driven by your relationship with this particular patient. You know, is this somebody who's like visibly nervous coming to you for the first time, you know, is 17 or 18 and is like, this is their first discussion? Or is this somebody who's 35, 40 and is coming in and saying like, yeah, you know, like this hasn't worked for me in the past. Like, I don't like this. I do like this. You know, there are times where when I will like give a patient even like one of the online like Planned Parenthood quizzes or something and say like, hey, you know, let's meet up again or have a telephone call in like a week or two and let you kind of like see what some of these options are so that they have like a buffer for that discussion if they're really nervous.
Mhm. Yeah, no, that's great. Thank you for sharing that. Sometimes people come in and they just know what they want, and there's really no need for like an in-depth elicitation or preferences. And so totally agree with that. I think what I like about these, and I'm just going to go back for a sec, is that just a reminder that we should be eliciting preferences and not just necessarily jumping into method. Because sometimes people are not aware of all the methods, you know, maybe they've only encountered one or two. And so I think it's helpful to at least get a sense of preferences before we jump into the methods discussion. But yes, that's great. A lot of people have a lot of experience and really don't need a ton of guidance. So any other thoughts?
Bianca, you don't have to answer this personally, but
Mhm.
I don't have very many female patients at my clinic, but I'm getting more now that we moved to Hobson. So I haven't actually had a ton of conversations about contraception in residency, but I do feel like it's like the one area of medicine that I have like personal experience with. And so I feel like I bring up my own experiences with different methods of birth control more frequently than like if a patient had, you know, abdominal pain or whatever. And I'm wondering how you feel like that goes over, if you feel like you should keep it more like less personal, or if it sometimes can help the rapport more to be like, this has been my experience, this has been my friends' experiences who use this method of birth control. Also, it's anecdotal, but like that's from like 10 of my friends using this and things like that. I've kind of found it helpful, but like I said, I haven't really done it that much.
Yeah, I think that actually what Ruth said, that it really depends on your relationship with the patient. I agree with that. Some people may like that and some people may not. And I think I will go back to, so I think that there have been some qualitative studies about physicians discussing their own relationships or like their own experiences with contraception. I'm not sure that they necessarily go either way, but I will go back to that patients who felt like their physician had a method preference did feel less satisfied. So I would just make sure before you start talking about your own experience that you really make sure you've had a chance to elicit the patient's preferences, so they don't also feel in any way coerced by your experience. But yes, I mean, I think that if you feel like it's right in that particular dynamic, it's okay. I have definitely used it in the setting of, I think people who are interested in an IUD but have some fears. I sometimes share my experience about getting an IUD, but I really try not to make it coercive again, because I had a particular experience doesn't mean they're going to have the same experience. And so, yeah, I would just use it sparingly.
Cool, thank you.
Yeah, it's kind of like with the COVID vaccine, where it's like, I got it, I tell all my friends to get it, but like with an IUD, I don't necessarily want everyone to get it. So it's like, I use my personal experience sparingly. Yeah. Any other thoughts or questions that people have at this point?
I feel like with Megan's question, when I talk to my folks, like there are some people that I will share my personal experiences with, and some whom I think that's not as appropriate. But whenever I bring up my own experiences, I also like put a ton of qualifiers on it, and to say like, hey, like, well, my experience may be different from yours because like I have a contraindication to this method or that method. But this was what was most important for me, and I felt like that method worked the best, or something like that. And that can kind of give you a little bit more wiggle room in terms of like not pressuring your patient and like giving them a way to say like, okay, I've contextualized that experience and I can add it to my info, but not feel like I must do the same thing.
Right. No, I think that's all great. And honestly, that for me is just a reason why I really want to systematize the idea of eliciting preferences first before we get into methods discussion. Because then you've made it clear that you understand what the patient prioritizes, and then you can get into the methods discussion afterwards. So, okay. If people don't have other comments, and I welcome more comments, I will move on. But if I'll give like 10 more seconds for people to put in their last little comments. All right. And if you want to return to this discussion, I thought this was a great discussion, so we can always do so. Okay, so just to continue our case, as a reminder, since it's been a while, this was a 43-year-old married woman with poorly controlled hypertension and anxiety. She was not on contraception when I met her, but she did not want to get pregnant. So we did talk. She was not super sure about what her preferences were, but she'd had a lot of experience with contraception in the past. She did not like injections. She definitely didn't want an implant. She had tried both the copper IUD and the Mirena in the past, but didn't like heavy bleeding with the copper and did not like amenorrhea with the Mirena. She wanted to just have her normal periods. And we talked about tubal ligation, but given her age and felt like menopause was coming around the corner, she didn't really feel like it was worth it. And so in the end, she actually kind of preferred to use the method she tried before and liked, which was vaginal rings. And so she chose that option and continued for about a year. And so just to quickly review types of contraception, this image was from the Bedsider website, which someone else mentioned, and thank you for mentioning that. It is a really helpful visual tool that is highly patient-centered to explore contraception options by preference, by patient's preferences, and then has a lot of like very down-to-earth articles about contraception and covering a lot of questions that people may have. So I highly recommend it. And it can also be helpful just to give people a full array of what their options are, because sometimes people don't necessarily know all the options. So, and then as far as starting a contraception method, the picture on the side is from the US Selected Practice Recommendations, which is something the CDC puts out about prescribing and following up contraception. And there's an app, which I just recommend having on your phone, which can be really helpful. But basically, you can start a contraception method anytime, as long as you're reasonably certain the patient is not pregnant. And the ways to sort of be reasonably certain a patient is not pregnant, they have to be within 7 days of the start of a normal menses, or not have had sex since the start of their last menses, or be correctly using a reliable method of contraception, or be within 7 days of a spontaneous or therapeutic abortion, or within 4 weeks of postpartum, or like full-time or almost full-time breastfeeding and amenorrheic within 6 months postpartum. So those are the criteria. Pregnancy testing is not one of the criteria for being reasonably certain that a patient is not pregnant. And so routine pregnancy testing is actually not necessary to start contraception on the day of the visit. And if someone is actually within that period where you are not reasonably certain, it's not, urine pregnancy tests are not always 100% reliable either. So if a patient has had recent unprotected intercourse, you're not reasonably certain that they're not pregnant, you should also consider offering emergency contraception as well as like contraception to continue from then on. And then as far as how long people have to use a backup method of contraception, for the copper IUD, there is no requirement for that. It works as emergency contraception and then it keeps working from then on. But for the other methods, you can see here kind of like how many days out from the start of their last menses and how many days of backup contraception they will need. And there's very little requirement as far as medical testing or screening to prescribe or to give birth control. And the only real things they recommend are a blood pressure check if you're prescribing a combined hormonal contraceptive method, like the pill, the patch, or the ring. And then a bimanual and a cervical inspection for IUD insertion, which you're going to need to do for the insertion anyway, but also you're screening for cervicitis. And then they recommend, and I'm not sure that everyone does this. I don't know that I've always done this. If you're prescribing a pill that you prescribe for 12 months, so there's not barriers to refills for the patient. And now we're going to kind of talk about different criteria for birth control and how we can match patients' preferences with the characteristics of the birth control. And so one criteria is efficacy. This is also, I think, a really nice visual aid from Beyond the Pill, which is UCSF website that also has really nice contraception visual aids. So there are ones that work really well, which means that less than 1 in 100 women will get pregnant in the next year on these methods. There are ones that work pretty well. So it's like 6 to 9 in 100 women will get pregnant in the next year. And then there's ones that really don't work as well. So it's about like 20 in 100 women that will get pregnant using these methods alone. And then there's also answers in the chat. Your patient has significant bothersome anemia from heavy periods. What are some contraception methods that you think may help with this? And again, we're all learning together. All right, I got some B's, some D's, a not C. Not C is definitely correct. Some A's, some B's. Okay. Great. And someone's mentioning kind of like extended cycle of OCPs. So skipping the placebo week. B and D, great. So yeah, I think that not C is definitely correct. As we all know, the copper IUD makes your periods heavier. Probably all of the other ones have a potential to help. And maybe the most correct answer are that the progestin only methods are slightly more helpful if people are having such heavy periods that they've become anemic because they thin the uterine lining. But that doesn't mean that the combined hormonal methods can't also be helpful. So, all right. Patient has mood swings and really bad acne with periods. What methods might be helpful here? A, okay, I got a couple A's. Okay, all A's, good. Yes, that's right. So let's talk about non-contraceptive benefits of contraception. So here are just some, and people may have others that they want to comment in the chat, and I welcome that. So if for patients that have painful periods, most of the hormonal methods are helpful, including the hormonal IUD, the implant, the depot shot, and combined hormonal methods like the pill, the patch, and the ring. For patients that have menstrual blood loss and anemia, the progestin-only methods may be a little bit more helpful because of the characteristic of thinning the uterine lining. But combined hormonal methods can also help just because they can make bleeding regular or reduce bleeding if you're using an extended cycle regimen. For patients that have acne or hirsutism or dysphoria or other kind of hormone-related menstrual symptoms, combined hormonal contraception is really helpful. And it's also used for things like, PCOS and endometriosis. And then lastly, some people might be interested just because they've heard about this or because they have a family history in how contraception affects cancer risk. And so both combined methods and the hormonal, I should have put hormonal here, the hormonal IUD decreased the risk of ovarian and uterine cancer. And in particular, OCPs are well studied to reduce the risk of ovarian cancer. All right, so the next questions are going to be about side effects. So your patient really hates spotting and irregular bleeding. Are there methods that you would not recommend here? And again, just put it in the chat. B, D, and E. Okay. C and E. E. Okay. F, C, D, and E. Okay. Everything but A. That seems to be what people are saying. Okay. Yes, and I want to make a distinction between heavy bleeding and irregular bleeding here. So I think the copper IUD causes heavy bleeding, but not necessarily like intermenstrual spotting or breakthrough bleeding, which can be associated with some of the other methods. And I think the next one is sort of like infamous for intermenstrual spotting. But yes, we'll go through that. A lot of these methods can be associated with irregular bleeding. Your patient wants to try to get pregnant after a few months and just really wants to kind of have contraception that covers for a few months. What would you not recommend? All right. So people don't recommend the IUD or the Nexplanon. And I see an E there too. Yes. Great. All right. Thank you all for your participation. That's great. So let's talk about side effects of birth control and understanding that some of these side effects, particularly with OCPs, have been studied in large studies, and there may be an element of placebo or attribution bias here. That being said, it's still really important to think about these side effects because whether or not in large studies they've been shown to be associated with birth control, if the patient is attributing to the birth control, it's going to affect continuation. And I think you have to be respectful of the fact that that is the experience that your patient had. And so for headache, basically all methods can be associated with headache. Similarly, most methods can be associated with nausea, but it's particularly associated with emergency contraception. And often we can prescribe an antiemetic with emergency contraception for that reason. And then also with OCPs and the patch. Again, breast tenderness, common with many methods, but often reported with the patch. Acne and hirsutism are reported with progestin-only methods, and often we use the combined methods to treat acne and hirsutism in patients that are on progestin-only methods. And then there's irregular bleeding, and there's also breakthrough bleeding. And you all were right when you said basically everything can be associated with this. Really very low dose combined methods or extended cycle regimens can be associated with breakthrough bleeding. The implant can be associated with both breakthrough and irregular bleeding. And depot, usually in the first few cycles, can be associated with regular bleeding, but that is supposed to get better with time. Depot is the only method that's really been shown to be associated with weight gain, as well as with mood symptoms. And there's really a lot of contradictory research when it comes to OCPs, particularly, and mood symptoms. Similarly, libido, no change really shown in most large studies of combined hormonal contraception. But we know that it decreases free testosterone and increases sex hormone binding globulin. And could that be associated with libido? Again, your mileage may vary depending on the patient. The vaginal ring can be associated with vaginal discharge. And then as far as delayed return of fertility, I think everyone was right when they would not recommend like a long-acting method to someone that wants to get pregnant within the next year. That being said, the only contraception method that's associated with a delayed return of fertility significantly after discontinuation is depot, because it's stored in the fat tissue. And so there can be an up to 12-month delayed return of fertility with depot, which is something that you should tell your patients about if you're going to prescribe it. All right, I'm going to try and go a little faster because we're running low on time. Patient resources, we talked about that. And now we're going to just briefly talk about medical contraindications. And again, I want to recommend this app, the US Medical Eligibility Criteria. The contraindications will be category 1 or 2, safe to use. 3 is a relative contraindication, which means it's okay to prescribe with shared decision-making. And 4 is sort of an absolute contraindication. And then the common health risks of contraception, the one that we usually always hear about is the VTE risk. So combined methods are thrombogenic, and the risk is about 2 per 100,000 person years, but that goes up with other vascular risk factors and with age. There has been shown to be an increase in breast cancer risk with hormonal contraception, but it's important to let people know if they have questions about this. This is a very small absolute risk. And then there's mixed evidence, or at least method-specific evidence relating to bone health. So depot does decrease bone density, but there's not a lot of studies or good evidence on other progestin-only methods and their effect on bone density. And then for combined methods in large population studies does not seem to be related to fracture risk or to bone density, but in adolescents who are in the bone formation stage, there is perhaps an effect of lower bone density with low dose OCPs, and the WHO actually recommends against low dose OCPs in this age group. And there's potentially a benefit to bone density in perimenopausal women, which kind of makes sense when we think about that we use estrogen to treat osteoporosis in postmenopausal women. So I'm going to skip this question for the sake of time and just kind of show you some of the medical contraindications that I thought were interesting or maybe surprising. I don't know if anyone else has thoughts about these, but just the common ones like hypertension, other cardiovascular risk factors. Smoking plus greater than 35 is an absolute contraindication if they're smoking more than 15 cigarettes a day. Prior clot, stroke, heart disease, complicated diabetes, so diabetes with neuropathy or nephropathy, bariatric surgery, migraine with aura, and then for the IUDs, PID or gonorrhea, chlamydia, cervicitis is absolute contraindication. But I just want to point out that TRIC and BV are not. It's really gonorrhea and chlamydia that are the contraindications. Any questions or thoughts about these? For our case, our patient's hypertension continued to be poorly controlled over the time that I knew her. And after some discussion, we decided to switch to progestin-only pills, given that her age and her poor hypertension control. However, at the next visit, she revealed so she actually stopped these because of breast pain and was just using condoms. So again, I know we're running low on time, so I want to be sensitive to that. But if people have thoughts about this was a hard visit for me because I actually felt really bad about convincing her to stop her previous kind of effective method of contraception that she liked. Because of the medical contraindication, and I wondered if I had overstepped my bounds as a clinician as far as affecting her choice of contraception. Do you have thoughts or experience about discussing medical contraindications or counseling patients on this? And the question, Lindsay, is bariatric surgery a contraindication to oral contraceptives because of changes in absorption? That is such a good question. I'm actually not sure, but I will look that up and get back to you all. Because yeah, I was surprised by that as well. Okay, if people don't have thoughts or want to save it for later, we can just move on. But just to say that my points here would be that category 3 is not an absolute contraindication. It's a prompt for shared decision making. And so you should talk to your patient and about the risks and then let them weigh it against the risk of pregnancy and then their preference for this versus another method of contraception. So there's some hard decisions to be made all around. And then in patients that are using less effective methods of contraception, like this patient that was just using condoms, you should offer emergency contraception. It's just a lot easier to already have a prescription and have this at home rather than try to reach for it after the fact. And the types of emergency contraception that are available are the levonorgestrel pill, which is available over the counter. It's less effective mainly because it's only effective in the first 72 hours after sex, and then it's less effective at higher BMIs. There is the prescription-only pill, ulipristal acetate, which is effective for a little bit longer period and at higher BMIs. And then there's the USP method, which I'm not going to get into. It basically involves using your oral contraceptive pills as emergency contraception, and it's a little bit less effective than the other methods. And then there's the copper IUD, which is the most effective but highest barrier type of emergency contraception and requires an appointment and a procedure. So in this case, this patient actually ended up having unintended pregnancy after several months of just being on condoms, and ultimately ended up having a spontaneous abortion and then decided to get a vasectomy. And so my point here is just think about emergency contraception, make sure that you're doing shared decision making with your patients when you're weighing medical contraindications. And then also, I don't think I ever talked to her about vasectomy, but that actually was a really great contraception option for her and something to think about in the right patient. So I see a comment that the recommendations are comparing the contraception versus not, rather than the contraception versus pregnancy, and pregnancy may be a truly riskier state. Yes, I completely agree with that. Thinking about the risks of pregnancy versus the risks of contraception. Okay, I'm going to go really quick. I don't think we have time for this next case, but I will just be very quick here. So this was a patient that also came in for an established care visit after heavy vaginal bleeding. And had a lot of STI risk factors, including a male partner that had unprotected sex with many other men. We were discussing contraception counseling. I'm going to skip these questions because we don't have a ton of time, but I'm sure that after the last case, you're all very able to kind of elicit preferences and talk about methods. But my point for this case, which I'm sorry I didn't have time to get to, is just that pregnancy risk comes with STI risk. And so when we're counseling on contraception, we should also assess STI risk, offer STI testing, and offer PrEP in patients that are at risk of HIV. And so in this particular case, after counseling, this patient was interested in IUD for her really heavy, significant vaginal bleeding. I did screen her for STIs and she tested positive for gonorrhea, chlamydia, and syphilis, which were treated a little trickily given a penicillin allergy. She was not interested in PrEP, and then she did end up seeing OBGYN, but unfortunately due to active cervicitis, an IUD was deferred. But thankfully did not have heavy bleeding after that and is going to go back and get an IUD. So my takeaways, thank you so much all for your patience and listening. It's a comment. Both these cases bring up a great point to discuss contraception and STI prevention with your male or transfeminine patients and your partner's male or transfeminine patients, partners. Yes. Thank you. I love that point. So I hope that takeaways from this are that you're going to discuss your pregnancy intention and contraception with any patients that can conceive, and work on keeping contraception on the agenda, understanding that people's needs may evolve over time. And that shared decision making is really important, and that our counseling should always center patient preferences, and we should make sure we understand those preferences before we jump into recommendations or talking about the details of methods. And we should consider that patients may have had past negative experiences, and there may be histories of injustice that are informing our current encounter. I hope you understand the resources you can go to, including the CDC medical eligibility criteria for medically complex patients, and also that you'll feel empowered to prescribe category 3 with shared decision-making with the patient, and that you will consider STI risk and HIV risk where appropriate, and keep emergency contraception in mind when patients are using less effective methods. So I will take any questions. Yeah, I was like, is it inappropriate to put a picture of my babies on this contraception talk? But I thought it'd be cute, and also sometimes you want to ship them off. And so thinking twice about getting pregnant, I thought was an appropriate thought. So
Never inappropriate. This is such a cute picture, and your kids are so cute. So I'm glad it's included.
People have thoughts or questions. There were a lot of great comments in the chat, which I loved. So thank you for all that.
Yeah, Ruth added in the chat, both of the cases bring up a great point to discuss contraception, STI prevention with male and trans. Oh, sorry, I think you already said that. I apologize.
Yeah, just that. Yeah, definitely thinking about the partners and how the partners have a role to play in both contraception and STI risk.
Yeah. And Amelia's asking, great question. Besides vasectomy and condoms, are there other contraceptive methods geared towards people who produce sperm? I heard about non-hormonal pills being researched.
Yes, there is research. But nothing FDA approved on contraception for people who produce sperm.
If you're interested in that, John Amory in the Department of Medicine does a lot of research and has a specific interest in that. Yeah, I think there are things out there, but
yeah. But yes, vasectomy. I don't think I regularly include that in my counseling, and I think after that case, I will do so in the appropriate patient. So. Any other thoughts, comments?
Comment from Ruth. So many of male patients ask about reversible contraception for men. It's always a good chat. Frustrating for both of us, but good.
Yeah, I mean, I hope that we'll see more, because obviously some people are interested in that, and that's great. So yeah.
And I'll just say this was an incredible and excellent presentation, Priyanka. Thank you so much. I think brought up a lot of really, really important points to talk about with our patients when we're talking about contraception. And this was incredibly helpful for me. So I'm seeing a lot of gratitude in the chat. Thank you. Very helpful.
Great. Thanks. Yeah, I hope it was a good refresher for everyone. So thanks, guys. I'll stop sharing.
And please feel free to include adorable pictures of your kids in any any presentation going forward. All right. Well, maybe we'll wrap up there. Thanks so much, everybody, for being here this morning and participating. And thanks to our speakers today. And hope that you all can get a little bit of sun for a little bit. Looks like it just came out. And have a wonderful afternoon wherever you're going.